Face and TMJ. This is our final slideshow presentation for the semester. I want to thank everyone for their good time and attention throughout the semester. Hopefully you've learned a lot. This will be your last slideshow presentation for all of your anatomy for PT school. So this is one of my favorite ones to do. And this is one of my favorite ones to do because of a couple things. Literally, this is the culmination of says what it is and is what it says. And you're going to see that throughout the myology that we go over. The other thing that makes this presentation so awesome are the faces that are associated with all the muscles. This is a hilarious one. I really enjoy doing face and TMJ. So looking at the muscles of facial expression. In general, they're going to be innervated by various branches of the facial nerve. Now remember, facial nerve is cranial nerve 7. Think over to neuroanatomy. Definitely know where that cranial nerve exits the skull. Know where it exits off of the brain. Obviously, it's coming out of a cranial nerve. That's why it's called cranial nerve. And really, these are so important because these really provide a lot of nonverbal communication for us as human beings. Think about communicating without any sort of facial expression. It would be very different. So looking at the orbital group of muscles, what we're looking at here are obviously we're looking at all of the muscles that surround our eye. They allow our eye to close. Obviously, closing our eye is a very large function, and it has a lot of applicability to things like wetting our eyeballs or making sure that nothing is flying into our eye, like a fly or a stick or something other that we really don't want in our eye. So take a look at these muscles. First one we're going to go over is orbicularis oculi. Again, says what it is what it says. It is a muscle that surrounds the orbit of the eye. Okay, and that's exactly what orbicularis ori means. I'm sorry, orbicularis oculi. So take a look at this muscle. This is the corrugator superiliu. So this is going to be our muscle that's right in between the eyes, and this gives us that kind of worried look or a little bit maybe of a frustrated look. So this is going to be a very key muscle in kind of furrowing our eyebrow. Very different muscle here. So this muscle is called a nasalis. So just by knowing what nasal means, obviously this muscle is going to be located right around our nose. Now we're going to have two different parts of the nasalis. We're going to have a transverse part, and that's going to compress the nares or the nasal openings. And then we're going to have an alar part that's going to dilate the openings. So this is always kind of a fun one to practice in the mirror. So if you want to study the facial expressions really well, what I would suggest doing is use this PowerPoint slide, go in front of your bathroom mirror, and practice each of these motions, and you really get a good sense for where all these muscles are located. So now the prosciuttus. Prosciuttus is a muscle that obviously squinches up our nose, squinches up kind of the eyebrows. I like to call this the stank face or stinky face because it kind of gives that look like, ooh, what's that smell, right? So really kind of look at this muscle. Other thing to do with this PowerPoint presentation, not only practice these in the mirror, have the muscle chart right next to you, okay? Because this is going to be a purely lecture-based module because there's not going to be a ton of lab associated with this sort of material. So this is the depressor septi nasi. Again, says what it is what it says. This is going to depress the nasal septum, which, as you can tell by the picture, kind of gives you that hey, you want to fight, or what I like to call the thug look, right? So this is that picture that, if you don't want someone to mess with you, you're going to contract, you're going to activate your depressor septi nasi. So this is the orbicularis oris. I like to personally refer to this muscle as the duck face muscle or the selfie muscle. I can tell you that, obviously I have a couple kids. They have a very healthy social media presence, so they have very developed orbicularis oris, because this is the muscle that's going to kind of pierce our lips or purse our lips together. This is the buccinator. So the buccinator is going to kind of blow or open up the cheeks. Okay, so typically the buccinator is called the trumpeter's muscle. So definitely know where that muscle is. This is going to be one of the more developed muscles that we have in the maxillary region. So taking a look at these muscles here, now we're getting into kind of the muscles that surround the mouth, surround the face, in the maxillary, and even some of the mandibular region. So take a look at this. Spend some time with this picture because we have three different muscles here. We have depressor anguli oris, okay, so the angled muscle around the mouth that's going to depress it. We have the depressor labii inferioris. That's going to bring the bottom lip, or what's known as the labia, downward or depress it. And then we also have the mentalis. And mentalis just means chin. So you kind of think about it, we have an angled muscle that depresses our mouth. We have a muscle that depresses our lower lip. And then we have a muscle that attaches to the chin. When we look at the oral group of muscles, we have a couple different ones here. Like I said, we have, and you can see this from the previous slide, these are the muscles that we're going to use when we frown. Okay, so depressor anguli oris, you can see that labeled. You can see depressor labii inferioris labeled, and you can see mentalis labeled. Now, it's very interesting to note that it actually takes a lot more muscle and a lot more contraction to make that face, right? So obviously this is a face that in PT school we see every once in a while, and I'm sure I made it when I was in PT school too. But just understand that when we frown or when we bring our mouth downward, these are the muscles we're contracting to perform that action. So looking at the upper group of muscles around the mouth, the muscles we're looking at here are the rhizoris and the zygomaticus major and minor. So with these, really simple again. Just understand that rhizoris is going to be the more horizontal or more transverse plane muscle that's featured. Zygomaticus minor and major are going to be more of an angled muscle upwards towards the cheekbone or towards the zygomatic arch. That's why they're named zygomaticus. They attach to the zygomatic arch. So full disclosure here. Growing up, I was the oldest of 4 kids. I can tell you that my younger sisters used to use their rhizorius and their zygomaticus major and minor a lot, especially when they got me in trouble. So what I want you to think about is when the rhizorius contracts, my mouth widens a little bit. It stays closed, but I can bring my mouth closer to my ear. Zygomaticus major and minor are going to be that upward and angled upward motion. So definitely understand how both those muscles contract and what motions are going to happen when they contract. Like I said before, practice these in the mirror. Go over each muscle, go over each attachment, and then practice the motion. So in looking at this group of muscles, again, this is going to be another muscle that if you want to prevent getting in a fight, you're going to use this muscle. Okay, so you're going to use levator labii superioris, which is going to elevate the upper lip, and you're also going to use levator labii superioris leque nasi. So all that really means is I have a muscle that elevates or levates in Latin my upper lip, and I have a muscle that elevates my upper lip, but it's also attached to my nose. And that's really all those two muscles mean. So again, says what it is what it says. Don't get too confused with the terms here. Just understand what each of those mean, and then understand the motion that's going to happen when those muscles contract. So taking a look at this group of muscles, now we're actually going to see the levator anguli oris. Okay, so this muscle is going to obviously elevate the mouth. It's going to bring the mouth upward. However, understand that this muscle is deep and lateral to levator labii superioris. It's also deep to zygomaticus. Now, we're going to see here in a second what motion those muscles are going to make. So as we can see, this is kind of that confused look. But what's really interesting to note here is you can bring and you can contract half of those muscles. You don't have to contract it bilaterally. So very interesting to know, but just understand what those muscles do and where those muscles attach, obviously. So this is platysma. Platysma is a very large, flat, thin sheet of muscle in the superficial fascia of the neck. This is that muscle that you can kind of see contract as you're bringing your face upward, like if you're making a scared or anxious face or you got shocked by something, and you can see everything in your neck and your chest kind of rise with it. Platysma is responsible for that. So it basically just functions to tension the skin. So really just understand that. Also understand that platysma is innervated by the cervical branch of the facial nerve. Like I said earlier, the vast majority of these muscles are going to be innervated by the facial nerve. So just understand the different branches that obviously innervate them as well. All right, ear muscles. Auricular muscles are the official term for ear muscles. I am very, very jealous of anyone that can wiggle their ears. I have not mastered that feat yet. So just understand that what we're going to see with our auricular muscles, we're going to have muscles that pull the ear superiorly, anteriorly, and posteriorly. Okay, so just understand where those muscles are, where they attach, and then obviously what actions are going to happen when we contract those muscles. So occipitofrontalis, really interesting muscle. Big thing to note with this one. This is going to trip up a lot of people. It trips up people every single year. Two bellies, one muscle, one really huge tendon that connects the muscle. But as you can see, it looks like two different muscles, right? We have a muscle in the front and we have a muscle in the back. You could even argue, say we have two bellies in the front and two bellies in the back. But it is definitely the same muscle, and I want to make sure I emphasize and I want to make sure that you understand when we talk about occipitofrontalis, it's one muscle and one muscle only. So getting into a little bit of glands, this is the parotid gland. So parotid gland, as we can see, sits just anterior and inferior to the ear. What we need to understand is what the parotid gland does. What I want you to do is I want you to dig that one out of your textbook. I want you to figure out what the parotid gland does, why it's important, and why we have it. And then start thinking about why is it located where it is, because it's actually located in a very strategic location. So here's what we know about the parotid gland. It can get inflamed. It is very commonly associated with disease called the mumps. So the mumps is something that the vast majority of people are vaccinated for as infants. But what it is when it gets infected or gets inflamed, you have these very large welts. It almost looks like you have walnuts or a lot of marshmallows in your cheeks. So it can be infected by bacterial infections as well. Sometimes there's a duct that gets blocked as well. And then sometimes, and every once in a while, you're going to see this, you're going to have tumors that actually develop in that parotid gland as well. So the facial nerve, this is why the facial nerve is important. Bell's palsy. Now, here's why Bell's palsy is important. What you have to do is you have to differentiate it. If you think about it, if I have palsy in my facial nerve, I'm going to have a facial droop. Okay? The most common associated pathology with a facial droop is a cerebrovascular accident or a stroke. So you as a physical therapist have to figure out, is my patient having Bell's palsy or a palsy of the facial nerve, or is my patient having a cerebrovascular accident? So at this point, pause the slide, show presentation, and think about how you would differentiate, is my patient having a stroke or do they have Bell's palsy? So take a look at the facial nerve here. When we're looking at the facial nerve, obviously the facial nerve is going to have three branches. It's going to have a temporal facial branch, styloid mastoid branch, and a cervical facial branch. So understand what each of those branches is going to be responsible for. Understand that the facial nerve does have three different branches. So when you look at identifying those, potentially on a lab exam, make sure you can identify that facial nerve and each of its branches and be able to name those branches. So a little closer look at the facial nerve here. I really like this picture because it shows you exactly what each branch is going to be responsible for. So spend some time with the slide. Understand where the blue branches go. Understand where the yellow branches go, the purple branches and the green branches. And then start correlating where each of those muscles are going to be. Start correlating where that muscle will get its innervation from. So taking a look at the trigeminal nerve. So remember that trigeminal just means tri, means three. So I always kind of look at this like as a trident style of nerve. It's going to have three different branches as well. Those branches are called V1, V2, and V3. And then what we need to understand about the trigeminal nerve is that the trigeminal nerve is going to innervate the muscles that move the jaw, or what we call the muscles of mastication or chewing. Also remember that trigeminal nerve is a mixed nerve, so it's also going to carry some sensory fibers along with motor fibers as well. So looking at V1, this is called the Ophthalmic Division. So ophthalmic, think ophthalmologist, think eye. Okay? So where the V1 branch enters the orbit, it's going to be the superior orbital fissure. Again, go back to neuroanatomy. Make sure you know all your skull bones. Make sure you know all of your exit points and enter points. So the V1 branches out into three different smaller branches. The nasociliary, again, says what it is what it says. It's going to go to the cilia of the nose. The lacrimal nerve, which is going to hit your eye and with tear ducts, and the frontal nerve. So taking a look at V2, this is called the Maxillary Division. Obviously it's called the Maxillary Division because it runs in the maxillary area, or that upper part of your jaw. So it's going to exit through the foramen rotundum, and it's going to have sensory branches. It's going to have the meningeal branch, zygomatical temporal branch, zygomatical facial branch, and the infraorbital nerve. So just make sure you know those. So in taking a look at the mandibular branch, this is going to be V3. We're obviously going to have an exit point through the foramen ovale, but also know the branches. It's going to have a motor innervation. It's also going to have sensory innervation. So understand where it's going to go. Now this gets really easy if you just kind of think about where those structures are located. If I know where the structures are located, I can pretty well trace out each of those branches. So we just need to make sure that we can do that. My suggestion is to draw it out. Take a skull or take a drawing of a skull and draw out each of those branches as a better way to learn this material. So taking a look at the trigeminal nerve, cranial nerve 5, here's why it is important. There's a situation, there's a pathology out there called trigeminal neuralgia. And what it is severe split-second pain in the cutaneous region of the trigeminal nerve. Now again, very important because our patients are going to have mouth pain, eye pain, skull pain. You know, a lot of times this commonly gets associated with something like a migraine. And what happens a lot of times is that they actually do have a trigeminal neuralgia because they're having some sort of other pathology go on. So when your patient comes in and starts complaining of these things, go back to the anatomy. Go back to exactly what you're seeing and go back to and think about all the structures that are involved. Now take a look at this slide. This one is not only an important slide for this coursework, but also for neuroanatomy. Also next year when you look at neuro rehab and especially vestibular rehab. You're going to know next year that there's a really, really close correlation between what happens in my inner ears and what happens at my eyes. So really great way to check cranial nerves 3, 4, and 6 is to have your patients do voluntary eye motions. But understand which of those cranial nerves contracts and performs each of those eye motions. So looking at additional innervation to the head, honestly, we've gone over this stuff last semester. So understand that dorsal rami C2, C3, that C2 is going to be the greater occipital nerve. That's going to provide cranial innervation to the posterior cranium. Third occipital nerve, we can obviously see where that goes. That's going to be a little lower, more into what we consider kind of the neck region or distal to the skull. Ventral rami C2 through 4, that's going to be, and think about what ventral rami do. So that's going to be offering innervation from the cervical plexus. We kind of went over that last semester as well. And what you need to understand here is where each of those go and what each branch actually innervates. So this is another slide. This should be a lot of review. We've gone over this. We went over this last semester. So think about the arteries. Think about that branch off of the internal carotid and the external carotid and start thinking about how that branches out into the face. My suggestion is get out those slides that we talked about last semester and use this slide to supplement those slides. Now, looking at the vasculature to the face, we're going to have branches off the facial artery. This is kind of where we left things last semester. The facial artery is going to have a superior labial branch. It's going to go to the top of the lips, and it's going to have an inferior labial branch, which is going to go to the lower lip. So just understand when we talk about how blood gets to the upper and lower lip, those are both going to be branches off the facial artery. So looking at other branches off the facial artery, obviously we're going to have something called the angular artery, which is just going to angle up towards the nose. And it's also going to anastomose with the ophthalmic artery. And there's also a very small branch called the lateral nasal branch. And that's going to come off the facial artery and it's going to go along the side of the nose. So hopefully you're getting a good appreciation for how much blood and how much nerve we have going to our face. And this is exactly why, the face bleeds as much as it does when we do have an injury. And this is why it hurts so bad. You think about all the nerves we have, all the specialized muscle, all the specialized cutaneous innervation, and obviously all the specialized blood supply, both from an arterial standpoint and a venous standpoint. So looking at the branches off the superficial temporal artery, obviously we're going to have a group of 3 branches off of this one as well: a frontal branch, parietal branch, transverse facial artery. So just understand where these branches go, understand what these branches do, and then understand that these are all branches off that external carotid. So what I want you to do is kind of trace it up from the heart if you have to, and trace up, okay, what's the internal carotid branch doing, what's the external carotid branch doing, and then how's that external carotid branch then branch out into each of its levels. So take a look at the maxillary artery here. So we can see the maxillary artery. It is a branch coming off of the external carotid artery. Again, this is where we kind of left things last semester. Now, the maxillary artery is going to have 3 branches. An infraorbital artery, obviously going just underneath the eye. A buccal artery, which is going to supply blood to the buccinator. And a mental artery. Remember, mental just means the chin. So this is an important slide to know. And not just because this guy looks like something out of a horror movie, but because this slide really gives you a nice idea of where the blood's coming from when we're looking at the blood supply of the face. So the black is coming from the internal carotid artery via the branch of the ophthalmic artery. All the red is coming from the external carotid artery. Okay, so when we think about the front of the forehead, medial side of the eyes, that's all coming from internal carotid. Everything else is coming from the external. So definitely understand this slide. Spend some time with this slide as well. So here's our venous drainage to the face. Obviously what we're going to have here is we're just going to have a couple large veins all draining down into the external jugular vein. So just understand this, understand how that drainage system happens, and then obviously understand where that blood's going to. So obviously it's all going to kind of drain into the internal jugular vein and the external jugular vein. The TMJ stands for temporomandibular joint. Take a look at this joint. It is a synovial complex joint. What makes it complex is that there's a disc in between the two pieces of the joint. So between the temporal portion and the mandibular portion, there's actually quite a large disc. This disc is a huge source of pain for people. Sometimes the disc can slip out of place, sometimes it can get inflamed. It happens a lot. So just understand that the TMJ, when you look at it from a clinical perspective, has 3 different parts. It has a mandibular part, it has a temporal part, and then it has an articulating disc in between those bones. So now looking at the synovial capsule here, what we're looking at here is the area surrounding that TMJ joint. Understand the joint. Understand that really what we have here is not one joint, but 2 separate joint spaces. And the reason is because of that large disc that's in the middle. So there's a fibrous capsule that's surrounding the TMJ joint as well. This joint, like every other joint we have, has an open packed and a closed packed position. Take a look at the chart that I sent you via Blackboard for those closed pack and open pack positions, and just understand what that means for the temporomandibular joint. So looking at generally the arthrokinematics of the TMJ. The reason I say generally is because TMJ is a little different joint. What happens with the TMJ joint is we still have the roll and slide that we've had with every other convex and concave joint we've gone over so far, both this semester and last semester. Understand though that the slide and the rotation happen at different points because of that articulating disc. So sliding occurs during protraction and retraction and wide mouth opening. So when you have to say ah, that is more the slide. The hinge occurs in between the disc of the condyle and the mandible, and it occurs during opening and closing. So definitely be aware of each of those. So taking a look at the ligamentous support of the TMJ, what we have here is we have a couple different ligaments. We have a lateral ligament that's obviously sitting lateral to the TMJ. And then we have something called a sphenomandibular ligament. And that's attaching from the sphenoid bone down to the mandible. And what these ligaments do, you just kind of see it from the picture. Think about what would happen if that ligament got stretched. Think about what motions it would restrict. And then what you kind of see is how we have the kind of arc-like motion that happens when we open and close our mouth. The styloid mandibular ligament is going to attach The styloid process down to the mandible. Says what it is what it says. What its function or its job is to minimize the sliding of the mandibular angle in the hinge motion. So these ligaments, you're getting a pretty good sense, are all pulling and all restricting unwanted motion. We don't want our jaw to slide out all over the place if we're trying to open and close our mouth. So looking at now the muscles of chewing, or what's commonly known as the muscles of mastication. So in general, these muscles are responsible for things like biting and chewing and all that great stuff. Also responsible for some of the side-to-side motion that happens with chewing. They're all innervated by V3, the mandibular division of the trigeminal nerve. So this is the masseter muscle. So this is going to be deep to the facial muscles. What it does is it covers the ramus of the mandible, and it's kind of crossed out superficially by the parotid duct. It's going to have two parts: superficial part and a deep part. This is another muscle. Definitely know this one, because this is the muscle that's very important when it comes to chewing. Now, just by looking at the muscle here, you can see what motions it's going to create. It's obviously going to close my jaw, and it's also going to abduct my jaw if I contract it unilaterally. Blood supply and innervation, pretty easy. Blood supply is just a branch off the maxillary artery. Remember, we talked about that earlier in the slides. Innervation is going to be mandibular division of the trigeminal nerve. So here's temporalis. This is a muscle that if you close your jaw and put your hands on the side of your head, and I would welcome you to do that, you can feel this muscle contract. It is a very large fan-shaped muscle. So that entire area that you see circled is all one muscle. It's going to have anterior fibers and it's going to have posterior fibers. Obviously know the proximal and distal attachments and understand what that muscle does, what its action is. So what the action is of temporalis, it's going to perform a couple different actions. It's going to close my jaw. It's going to retract my jaw if the posterior fibers are contracting. It's going to abduct or deviate if it is acting unilaterally. And the blood supply, going to be a branch off the maxillary artery, and innervation is going to be the mandibular division of trigeminal nerve. So hopefully already you're starting to see how these actions, even though we have multiple muscles perform them, all share a lot of commonality in innervation, in sometimes attachment points, in sometimes blood supply as well. So lateral pterygoid, this is a muscle that's very, very common for a painful site. This is a muscle that I can personally say I have had dry needled. It wasn't that bad. And what we're going to look at here is a muscle that runs horizontally, and it's going to have two different heads. It's going to have a smaller superior head, as you can see from the picture, and a larger inferior head. Understand proximal and distal attachments. Also understand where the smaller head's going to be, and understand where the larger inferior head's going to be as well. So looking at the lateral pterygoid here, what its job is to protract the mandible, and it's going to do contralateral deviation. Don't get confused with this one. Okay, look at the arrow and look at the look at the muscle, and understand where that muscle is and how it's going to contract. So this is a muscle that, because it's in multiple planes, is going to have multiple actions. So taking a look now at the medial pterygoid. This one's going to be partially covered by lateral pterygoid. It's going to have an attachment site at the medial surface of the lateral pterygoid plate. It's also going to have an attachment site at the inner side of the ramus of the mandible. Definitely remember that one. It's not attaching to the outside of the mandible. This picture is a little confusing because what you have to note here is that they've cut away part of the mandible. So actually you're looking at the medial side or inside of the mandible, not the outside. Now taking a look at medial pterygoid here, what it's going to do is it's going to close the jaw. It's also going to do contralateral deviation if it's contracting unilaterally. Branches should be catching a theme here. Branch off the maxillary artery is going to supply blood. Innervation is going to be a branch of the mandibular division of the trigeminal nerve. This concludes all of the PowerPoints for the semester. I thank you guys for all of your attention and really appreciate everyone making the transition to online education for this coursework. Let me know if you have any questions, let me know if you have any problems, and we'll get through this, guys.